Hi, my name is Alexandra Snyder, and I am the Executive Director of the Life Legal Defense Foundation. We are a pro-life, pro bono law firm that handles a wide spectrum of cases involving the protection of vulnerable life. We handle matters involving the beginning of life, including forced abortion cases, conscience protections, and many more. And we also handle cases involving the denial of life-sustaining care. Now, I used to call these end-of-life cases until I realized that most of the time we're not dealing with the natural end of someone's life, but rather the forced death of a disabled or otherwise vulnerable person who is not able to communicate his or her wishes. Most often, these are relatively young patients, young adults, and even children who've had unfortunate accidents or illnesses. So what would this actually look like? For example, it looks like 39-year-old Melanie, who suffered a stroke that left her incapacitated. 24 hours later, doctors told Melanie's mother that her daughter would never recover and recommended that she be transferred to hospice care without food. 2 weeks later, we received a call from Melanie's fiance, who was concerned about the doctor's course of treatment or lack thereof. When Melanie first went into hospice, she was largely unresponsive. But her fiance noticed that over time she had started moving and she could blink in response to questions. At one point, he asked her if she wanted to live, and she clearly indicated that she did. Melanie's fiance called us, and we immediately contacted a local attorney. This was a challenging case because the fiance did not have legal standing to actually contravene the mother's decision-making authority, even though Melanie and her mother had been estranged for years. Our attorney went to court and eventually obtained a court order to have Melanie transferred back to the hospital. But the hospice refused to move her, saying that Melanie's family had agreed that Melanie would not want to live this way. So why did they think that? Probably because she made some offhand comment at some point while watching Million Dollar Baby or another movie, where a patient was hooked up to a ventilator and then said she wouldn't want to live that way. Now, it should be noted that Melanie could breathe on her own and was not even on a ventilator. And then I want to backtrack for a minute and explain why the hospital removed her food, but not her hydration, because I always thought if they want to kill a patient, why don't they just, it's a lot quicker to dehydrate somebody to death than it is to starve them to death. But this was because Melanie was a registered organ donor, and the hospital or hospice wanted to make sure that her organs remained healthy. Forcing starvation will often precipitate another cardiac event, and at that point, the patient can be declared legally dead and the organs harvested. Our attorney had to go back to court, and ultimately the judge himself had to call the hospice doctor and threaten him with criminal and civil sanctions if he did not immediately move Melanie back to the hospital with nutrition. Several days later, Melanie began to speak. Within a few weeks, she was well on her way to making a full recovery. Now, when I first became involved in this case, I did not believe that patients in the United States could actually be starved to death. I actually flew out to meet Melanie. I attended a court hearing where the judge took the attorneys into his chambers so that pretty much he could read the opposing attorneys the riot act. Since then, we've handled hundreds of similar cases, unfortunately, not always with the same happy ending, but we've seen many, many cases where if a patient is allowed to have some time for recovery, they do in fact recover. So why am I talking about this now? A few reasons. First of all, what saved Melanie's life was the presence of an advocate, in this case, her fiance, who was in the hospital and then in hospice with her. He could see exactly what was happening. And because of COVID and also because of some other reasons, many hospitals now are limiting or even prohibiting visitation rights altogether. Not only does this deprive the patient of beneficial companionship, it deprives them of a patient advocate. And in cases like Melanie's, where patients are incapacitated or otherwise unable to speak, patient advocates are essential. They can facilitate communication between patients and healthcare providers to ensure that patients' needs are addressed. They make sure patients are not being deprived of life-sustaining care and treatment. For this reason, the Centers for Medicare and Medicaid has issued guidance urging hospitals to allow in-person visits, even during COVID, for particularly vulnerable patients, including patients with disabilities. The tragic reality is that these patients are being discriminated against in healthcare settings. And this is not just my opinion. Even the American Bar Association reports that many healthcare providers hold negative views of disabled patients that compromise their care and treatment. Hospital visitation and patient advocacy are fundamental to protect patients from being denied medical care because of this perverse bias. Prohibiting visitation for vulnerable patients is tantamount to denying access to medical care and services. You need to know that federal laws prohibit discrimination because of a patient's disability. These include the Americans with Disabilities Act and other laws that have been enacted for this purpose. Patients have a right to a patient advocate who can communicate their healthcare needs and ensure that they receive the same quality of care as other patients. And again, these laws remain in full effect during COVID. In addition to COVID, however, we are also facing a radical shift in our culture that values death over the protection of life. Tragically, many people, including many healthcare professionals, do not believe that human beings possess inherent dignity. They do not believe that we are endowed by our Creator with certain inalienable rights, preeminent among those being the right to life. Instead, these people fight for the right to die and even the right to kill others whose capacity to contribute something of material value is in some way diminished. This utilitarian, materialistic worldview also holds that healthcare decisions should be made in light of what is called the greater good. And here we have a systemic problem that is only likely to get worse. A lot of our casework involves Medicaid patients or patients with inadequate healthcare insurance. They've been told they qualify for extremely low cost or free coverage, and then they are handed an insurance card. What they are not told, however, is that Medicaid only pays 30 to 40 cents on the dollar for the care that is provided to patients. When a patient shows up in the ICU with a significant brain injury, the hospital is calculating how long that person may have to be treated and the money that the hospital is going to have to pay out of pocket to provide that medical care. And this is where the so-called greater good comes in. In the case of abortion, the greater good in utilitarian terms means that unwanted children must be sacrificed so more resources are available for the rest of us. This is the premise behind Planned Parenthood and the abortion cartel. It is what Supreme Court Justice Ruth Bader Ginsburg meant when she talked about getting rid of populations that we don't want too many of. It is what Margaret Sanger meant when she said, when she talked about the gradual suppression, elimination, and eventual extirpation of defective stock, those human weeds which threaten the blooming of the finest flowers of American civilization. And that is a direct quote. Similarly, an quote unquote unwanted adult, someone who does not meet the requisite quality of life, can be sacrificed to preserve resources for other people. This was the argument that was made to Melanie's family and the families of so many patients we represent. Basically, doctors told her family that she was nothing more than a human weed. So how can you protect yourself and your loved ones to ensure that you receive the treatment you need? First, you need an advance directive. This is a document that expresses your wishes in the event you should become incapacitated. And advance directives typically have 4 components. In the first, you name a designated healthcare agent or proxy who you authorize to make healthcare decisions on your behalf. You're going to need to discuss your wishes in great detail with this person. Now, ideally, this person would share your beliefs, but they should at least be very familiar with the specifics of the type of care you want to receive. And in the second section, then you specify what care you want if you should become incapacitated through an injury or illness. Now, we recently had a case involving a woman who had a Catholic healthcare directive. She was very careful to select 2 healthcare agents who shared her religious beliefs about the protection of life. However, she did not specify in the document that she wanted long-term care, including ventilation and nutrition and hydration. The judge said because she did not specifically state that she wanted those things, she must not have wanted them. And he refused to allow her healthcare agents to elect those things or request those things on her behalf. So I recommend that you specifically state the type of care that you want in an advance directive. Number 3, you would identify the extent of pain relief you would like to receive and whether you authorize pain relieving drugs that may even hasten your death. And here you need to know that certain pain relievers can shorten your life, and in some cases significantly. This is known as terminal sedation. Often these drugs are used at the very end of life, but we've seen cases where patients are heavily, dangerously so, sedated because they are difficult to deal with. For example, we had a case involving a woman who was overweight and could at times be belligerent. She was placed in a nursing facility where she was heavily sedated, even though she never complained of pain. Her sister thought she was going to die and asked that she be allowed, excuse me, sorry, and asked that she be allowed to speak with their family pastor. But she was never lucid enough to have the conversation. We worked with the facility to get them to back off on the drugs. Not only was she able to talk to her pastor, she was actually able, excuse me, to get out of the facility and go on and live her life. And finally, you will provide instructions regarding the disposition of your organs and other body parts upon your death. This too is something you need to think about very carefully. If you are a registered organ donor through excuse me, through a checkbox on your driver's license application or renewal, please familiarize yourself with the details of organ donation. You need to know that organs are not harvested from people who are truly dead. I know, for example, that hospitals are not supposed to treat organ donors differently from other patients, but the reality is that people's personal views come into play in cases like this that involve decisions about life and death. Now, I personally recommend that people who are not sure about organ donations leave that decision to their healthcare proxy and get themselves off of the organ donor registry. That way, decisions can be made in real time rather than registering as an organ donor in advance. None of these things are easy things to think about. No one wants to believe they could become incapacitated, even temporarily. But not only do we need to think about these things and take action to protect our own lives, we need to talk about these things with each other, with our spiritual leaders, and with our elected officials and policymakers. Who else is going to uphold human dignity and the right to life if we are silent? Thank you. So that's a great question, Georgette, about the differences between a case like Melanie's and a case like the Terry Schiavo case, which many, many people are familiar with. So, I mean, ultimately, you're dealing with the same issue. You're dealing with somebody who, I mean, whether temporarily or permanently is disabled, is not dead, is not even brain dead, I mean, is nowhere near dead. In both of those cases, these women were able to breathe on their own. They just required a feeding tube for nutrition and hydration. So in those cases, they are very similar. Where they are a little bit different is that in Melanie's case, I mean, they waited 24 hours before they sent her to hospice. They did not even treat her. They assumed that she was not going to recover. And really, I hate to say it so crassly, but they were after her organs in that case. This was still a relatively young woman. She had had a stroke. I think they were looking at her heart, that her heart was probably still intact, her lungs. I mean, she had viable organs that they were looking at. And that was the pitch that the hospital made to her mother. She's not going to recover. Don't you want to do good and allow her death to mean something? The problem was she was obviously not done using her own organs. So, you know, and in Terry Schiavo's case, this was a long, drawn out situation where it was clear that Terry was not going to recover. Now, I will say that doesn't justify starving and dehydrating somebody to death, which is a cruel, I mean, it's a barbaric way to kill somebody. But in that respect, they were different. But in both cases, they needed an advance directive. They needed to make it clear on paper what they would have wanted. the problem is, though, that people don't often know what they want, because especially if you're young and you're active, you're looking at this not as a choice between life and death. You're looking at it as a choice between your active life and a life that possibly consigns you to bed or something like that for the remainder of your days. But when it actually comes, and we've seen this with patients who are able to express their wishes, when it actually comes to, this is your life now, not the way it was, this is your life now, or death, they choose life. They want to live, they want to fight. It's inherent in our human nature to want to fight. So yeah, I would just say, again, I just tell people, have an advanced healthcare directive, especially if you don't know how your spouse or your children or your healthcare decision maker is going to react to a situation like this, what kind of decisions they might make when you're not able to make those decisions for yourself. Yeah, that is a very good question, and a question that we're going to be dealing with for some time to come. Whether there is an actual constitutional right to healthcare from a federal perspective, I don't think there is an obligation for the federal government to provide health insurance. I think if you look at the Constitution, what the Constitution says, I don't think that obligation exists. I think this is something that needs to really happen at the state level. States and local governments are much more closer to their populations, know the needs of their populations. I think if you're going to have any kind of healthcare market or things like that, it needs to be at the state level. And that was even recognized to some extent anyway in the Affordable Care Act, where it did create these healthcare markets at the state level. I think the question is not so much, do you have a right to healthcare insurance? Because I think whether you can argue a constitutional right or not, I think everybody agrees that we want people to have healthcare insurance. I mean, we don't want people out there who are not covered and who are at risk. The problem is that healthcare is very, very expensive. And when you have, like I said, in the case of Medicaid, for example, you have a program that alleges to cover or aims to cover a lot of people, but does not include the funding for that type of coverage, you end up with these situations like Melanie and many more tragic situations where healthcare is very quickly removed when it becomes too expensive. And that's what we need to start addressing. I think we need to also look at, for example, under the Affordable Care Act, and maybe I'm getting too in the weeds here, but under the Affordable Care Act, you have families that are making $80,000 who are not required to pay anything for their healthcare coverage, or a minimal amount for their healthcare coverage. And so the perception is when you get something for free, you just don't value it. And I think we need to change that dynamic. In other countries where they do have even socialized medicine, and I'm not advocating for that by any means, but I'm just saying there is a much larger contribution on the part of the person who's receiving the coverage. So I think we need to acknowledge healthcare is not free. It will never be free. If it's free, it's not going to be good. We don't want that kind of healthcare insurance, and we certainly don't want it foisted upon the entire country. So, but we definitely want people to be able to be covered and to have access and fair access to healthcare coverage. This is a great question involving discrimination when it comes to healthcare access or healthcare insurance coverage. So I cannot speak really broadly. I can only speak to my experience. What we have seen, and I don't know if this has to do with healthcare access or if this has to do with response to what's happening to a particular patient. But in our case, we see many African-American families, many Hispanic families, many families for whom English is not their first language. And those are primarily the types of cases that we are called in on, or patients who just don't have a lot of resources, or their families don't have a lot of resources. So, and many times that these patients are Medicaid patients. So they qualify for Medicaid is a combination of federal and state healthcare coverage that is provided to people of low income, or sometimes people who are injured or sick. So, and that's predominantly the type of cases that we receive. So it's hard for me to talk about discrimination because I'm not looking at the rest of the cases. And I've had conversations with people about this to ask, is this inherently discriminatory, the type of coverage that they're receiving? I will say, I think it is wrong to hand somebody an insurance card and say, here you go, you qualify for this coverage, isn't this wonderful? And not tell them the significant problems inherent in that coverage. So many providers won't even take Medicaid patients at all, not just because the reimbursement rate is so low, but because the paperwork is, at least I've been told, is unreal. To try to get reimbursed in the first place is a Herculean task. So I think that is problematic. The other thing is that when you receive that kind of coverage, my understanding is you cannot supplement it with other types of coverage. So now you're stuck in this, really the bottom tier. Medicaid is bottom tier healthcare coverage. You're stuck in this coverage, and if you make more money or you have other resources, you can't even kind of supplement that with other coverage. And I think that's a problem. I also do, frankly, as I said before, except for people who are truly indigent, if somebody has an income at all, I think there needs to be a greater participation in the purchase of healthcare coverage. I think people need to realize that it is something that is, again, as we discussed before, this is something that's expensive and that's something that requires a contribution. I know that those are difficult questions and not everybody's going to agree with me. So, and I'm not getting to the direct issue of whether there is discrimination. I do believe that there is discrimination. At least we've seen it in the way that patients are treated when they get to the hospital. And I don't know if that's inherent discrimination because of their race or their ethnicity, or if it's because of the type of healthcare coverage that they have. I'm so glad you asked about patient advocacy, because as I mentioned in my discussion, that is really essential. We've just seen that where patients don't have a family member or don't have somebody who's advocating on their behalf, that things can go badly very quickly, and patients can be taken off of medical care and put in hospice or things like that, and not even given a chance to recover. And I'll just quickly cite my own brother-in-law as an example of that. So my brother-in-law earlier this year was very, very sick. His wife was not allowed to visit him. His children were not allowed to visit him. And he was fighting off sepsis and just a very, very bad infection. And at one point, the hospital, which in this case, it was a Kaiser, so it was hospital and healthcare insurer all in one, which is problematic. They called her and they said, do you want to put him in hospice? Because, he's not responding well and maybe he just needs to go to hospice pretty much and die. And she said, no, you never even discussed that with me. Absolutely not. I want you to treat him. And so they said, okay, we'll treat him. I mean, what in the world? What is that? And we see that a lot in cases, in the types of cases that we handle as well, where there's just, it's like, well, you know what? They're not responding that well. We could treat them, but really, should we? Because we're using a lot of resources for this person, and maybe it'd be better just to get rid of them. And more those discussions are taking place. And if a family member does not know that they can say no, they have the right to say no to that, and to advocate for continued treatment, then the person is sent off to hospice and in many cases doesn't live very long. In the case of my brother-in-law, he started to make such a good recovery, they sent him to rehab. So, I mean, he's on his way to recovering, but if his wife hadn't known better because she wasn't there, it would have been really easy for her to say, oh my gosh, I didn't realize it was so bad. Yes. Okay. We'll put him in hospice. So advocacy is essential for every patient, but particularly patients who are underinsured and then also who have a serious disability. And I'm not saying they come in with a serious disability, but because of a heart attack or a car accident or something like that, they are disabled as a result of a recent event. And as I mentioned, even the American Bar Association has taken note that doctors, it will discriminate against those patients. They don't give those patients a good prognosis. They don't fight for those patients. They don't think those patients are as worthy of treatment as other patients. So when you're talking about somebody with a disability versus somebody not, or somebody who can still communicate versus somebody who can't, there is absolute verifiable discrimination happening in those cases.